of Health meeting includes election of officers for the coming year. So let's get started with the Pledge of Allegiance, please. Kiki. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. So I sent out a message from Kevin from a couple of years back, almost exactly 2 years back, about the process for electing new officers, and essentially we'll accept nominations for chairperson, which will be seconded, and then vote. And as soon as a nomination is made that gets more than half of the votes, we'll have a new chairman, and then we'll repeat the process for vice chairman. I want to start by saying I've decided that I will not stand for any nomination because I think it's time to move forward and develop new leadership. So please do not nominate me. If nominated and elected, I will not serve. And so with that, I would like to open the floor for nominations for chairman of the Board of Health of the Township of Radnor for calendar year 2024.
I would like to nominate Alex Yiannopoulos.
Do we have a second?
Second.
Excellent, thank you. So we can take a voice vote then. Let's start in the room. Start on my left. Lisa.
Agree.
Agree.
Aye.
I think it's an excellent choice. Aye.
Aye for me as well.
Seth and Lisa. Seth?
Agree. Aye.
Lisa?
Agree.
Excellent. Well, then we have a new chairman, and you can run the election for vice chairman.
I knew you were going to do that one more time, David. Yes, very big shoes to fill, and a very, especially in terms of banging the gavel enthusiastically. All right, well, with that, we will go on to nominations for the position of vice chair. Are there any nominations?
I'd like to nominate Dr. Desidue.
Any seconds?
I'll second.
Okay.
Let's run the vote the same way we ran the last.
All right, so
Sorry. Old habits. My
sorry,
apologies.
I'm still taking the minutes and running the meeting for right now.
So, Lisa?
Aye.
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 Seth?
Aye.
Lisa Bannister?
Aye.
Excellent. We have a new vice chair.
All right, congratulations, Dr. Desidue.
So
Okay.
would you like me to continue to run until we decide how we're going to
I'm okay doing both for now because I don't think we have a super heavy agenda tonight. And then starting with the next meeting, Dr. Desidue, you'll be prepared to start taking the minutes for the next meeting? All right. And speaking of the minutes, the first thing on our agenda is the approval of the minutes from the last two meetings because we didn't have a quorum in December. So we're approving the minutes for the meetings for both November and December. Did anybody have any notes on the minutes for either of those meetings? Can I have a motion to approve the minutes for the meetings for November and December?
I would move to approve. Do you want to, unless there's, we could do them joint unless there's any.
Yeah, I was going to just do them as one
Fine.
vote.
Move to approve.
Second,
I'll second.
all in favor?
Aye.
Aye.
All right.
Aye.
Aye.
All right, and with that, our next thing is organizational issues. I think the main one for this meeting was the election of officers. I'll just use this time to make a quick note that David has been a great chair of the board. I think, Lisa, I don't know if he was chair when you joined, but other than you, he was? So, oh, okay. So other than you, we have 7 other members of this board who have known no other chair of the Board of Health until tonight, even including our interns and Maggie. You led our board through a pandemic that went way longer than anybody thought or hoped that it would go, and through a transition of us establishing the first county Department of Health that Delaware County has ever known. So I'm sure on behalf of the entire board, thank you for your excellent service to the township and your continued service as a member of the board.
Well, thank you for your kind words. And your initial comment is exactly why I think it's time to move on. And I'm thrilled that you're there to come on board, and that Bob has agreed to take on the role of vice chair. I think it's excellent.
All right. And then with that, we have our next agenda item is community infectious disease follow-up. David?
Thanks. I think it's worth a couple minutes on infectious diseases. So the big 3, RSV, this year was a normal RSV peak occurring at a normal time, and a relatively heavy RSV peak, which is already well on the way to resolving. And that's all I'll say about that. Flu, on the other hand, is another normal season, but it's nowhere near well on its way to resolving. We're smack in the middle of flu season. We're surrounded by states that have high levels of activity. Our locale is at moderate levels, but the surrounding areas were at moderate 2 times ago and high since. So it's coming. It is a relatively normal flu season. It compares very well to the 2019-2020 season in terms of timing and intensity. It does not appear to be a particularly vicious version of flu, in that mortality levels at this point are not terribly high, although there have been, when I last looked, which would have been last week, 9 pediatric fatalities nationwide, and that's not insignificant. It is not too late to get your flu vaccine, but it's getting to be too late to get your flu vaccine. And if you're going to be out in public, I think that it's a really good idea to get yourself vaccinated. I don't think we need to spend a huge amount of time going over the fact that prevention includes don't go out in public if you're sick, and for flu and RSV and a lot of the other diseases out there, hand washing is critically important. It's not just a respiratory spread. Speaking of respiratory viruses, COVID is everywhere, and we have had the tribulation and privilege of seeing something that's probably happened a lot of times in the history of humanity, and that is a novel, vicious virus enters into a naive population and causes a significant amount of mayhem, and the way that ends is almost always through endemicization, which is the process we're seeing now. And at this point, I think the public in general has very little interest in any mitigation. The general interest of the public appears to be to forget that this pandemic ever happened. Truthfully, COVID is not done with us. And what has happened is we've become an exceedingly bifurcated population where lots and lots of people are getting it, and the overwhelming proportion of people who get it will get a syndrome that does not look too different from a cold, a flu, a severe winter viral syndrome. But a couple of things are different. One is that A, it's not a seasonalized virus. The peaks have occurred in virtually every month of the year. 2, there is a subpopulation for whom COVID is not a benign disorder. It is not even as benign as the flu. We are accumulating millions of people who have a post-COVID syndrome, long COVID, doesn't matter how you want to say it, and there are still a lot of people who have a significant acute risk from developing COVID. And so although most of the people in this room, I believe, are likely not to have a severe syndrome, they may well have parents, children, other relatives who do have significant risk, including acute risk or risk of triggering a recurrence of the post-COVID syndrome that they've had. So I would just caution people not to be completely cavalier when you are going to be in large gatherings of people that you don't know where they've been, that taking precautions should be completely encouraged. There has been some disinformation out lately about the new vaccine. The new vaccine is actually holding very well. It's providing excellent protection from hospitalization and severe disease. There was some disinformation about DNA contamination. Let me tell you that DNA contamination can occur in virtually anything that you might take, and nothing is without risk, but the issue is what's the risk of doing something versus the risk of not doing something, which is the last thing I want to take up in community infectious diseases. You will probably have heard about an outbreak of measles. So measles, polio, smallpox, I bring up those three. In the history of mankind, one of the ways that we've gotten from having people have life expectancies in the 30s to 40s to life expectancies in the 70s and 80s, after safe water and safe sewage, one of the great boons to increasing life expectancy has been the availability of vaccines. I'm talking about vaccines in general. And this notion that all vaccines are problematic or that this particular brand is problematic, no vaccine is perfect. They all have their risks, but virtually all of them have greater benefit than risk in the populations for whom they have been developed and tested and approved. And I think that we just have to put a flag in the ground and say enough with this lunacy and insanity of casting doubt on some of the pillars that we have that have made our lives what they were. And if you have doubts about your vaccinations, you should talk to your healthcare provider. But the notion that all vaccines are bad is we've just got to get rid of that kind of talk. And that's enough of my rant.
And I want to thank you for that, David, because we did have a comment at our last meeting that I thought, was frankly some misinformation that I'm glad you are. I don't know if you're specifically responding to that or not, but we have a policy that we don't directly respond to comment in real time, but I think it's important for us to say that vaccines work. David just named a number of diseases that they have eradicated or up until recently had eradicated in this country.
Sorry, I wanted to close that loop. We had all but eradicated smallpox from the globe.
Yes.
We had all but eradicated polio from this country. We had all but eradicated one of the most infectious viruses out there, measles, from this country. And anti-vax sentiment and poor judgment have resulted in the outbreak. And part of that, I believe, polio. Most of the people who are out there have never seen a child on a ventilator from polio, or parents grieving for a lost child from polio, or a child in a vegetative state from encephalitis related to measles. So they don't understand the risk. All they hear about are the side effects. Well, the risk is really, really high, and you just can't ignore the risks because the potential exists, and everybody has to make their own decisions, but it's a bad turn.
I think the other thing to note about these viruses you're talking about now, the polio, the measles, is they are so much more infectious than COVID or the flu. I mean, they don't even stand up to how infectious measles is.
Any other board comment on community infectious disease? All right. So with that, we will move on to updates from the county and food inspections. I do want to, before we get into the food inspection report, make everybody aware. So the county has started sending out these pouches in the mail. I got mine, I want to say within the last week. I live in a tiny apartment with an equally tiny mailbox, but they still fit in the mailbox. They do not expire, so if you don't need it right now, you should keep it around until you do need it. It's called the Deterra Drug Deactivation System. It works for pills, including gel, capsule, and tablet forms. It works for up to 6 ounces of liquids and even 6 of the transderma patches, that like the nicotine patches or anything that works like that. You just take it off, stick the sticky end on a tissue, and then put it in, and it works for that as well. We have a fair number of safe drug disposal events that occur at different places in the community, but this is a great at-home solution that the county has been kind enough to provide everybody with. So keep a lookout for it in the mail, and as I said, it doesn't expire, so if you don't need it right now, keep it somewhere safe in the house so that if you do need it at some point, you will have it.
I already use mine.
Okay.
And I just, sometimes directions need to be step by step. Don't put the pill vial in there. Dump the pills in.
Thank you very
Just
much.
saying.
That is very important to note, that is how it works. So we have that update. And then for food inspections, it's actually going to be very quick because we only had 3 food inspections in the month of December. There really was just one issue, which was there were some pest issues at Cabrini College. There's a follow-up inspection that actually was scheduled for today. I'm going to take a guess that maybe with the weather, that might have been rescheduled to a day when it was safer for vehicles to travel. But nothing really of note this month on the food inspections. And with that,
Can I ask, when does Cabrini actually shut down? End of the school year this year?
I actually don't know about that.
Okay.
I believe it is the end of the school.
Okay. Yep. So the next thing is old business. The first thing for that is the Savage Sisters program follow-up. I don't know that we really have anything to say about that because we're going to have the whole program later. For anybody who is listening, we are still live and in person in the township. For anybody who, of course, make your own decisions about what the roads are like near you, and please do not get injured on the way to a Board of Health meeting. But on the other hand, if you do feel that you're able to come in safely, we are going to be here in person for that presentation. And then our next thing is the oral health program. Robert?
So as far as the Colgate dental van, I'm still planning on Arbor Day, which I think was changed to May 6th, Friday at 5:30. So that's our tentative plan for bringing the Colgate van. I haven't made any contacts with the school district as of yet with the new person that might be helpful in getting the schools involved.
Okay, and I can make sure that you got Panayota's email. Yep, Panayota?
I'm sorry, I can't really see anybody, so I don't mean to be butting in or interrupting, but if you'd like to reach out, Alex can give you my email and we can talk offline and see what we can do for this year.
All right. Anything else under old business? All right. With that, we have the student intern program follow-up. So I'll turn it over to Julie and Lisa.
Chloe and Finn.
And Chloe and
So we have been having a few meetings, Chloe, Paniota, Julie, and I, over Zoom to discuss. We're really trying to finalize the survey that Chloe plans to distribute via, I think, Schoology, Chloe, hopefully by February, sometime in February. So we're really trying to hone in on some of the questions that can get at the relationship between chronic lack of sleep and some mental health issues. So Chloe, do you want to say anything about that?
Yeah, but our last meeting we discussed a timeline for it. So we've discussed some questions and I sent it to them this morning just to look over. But once everything's good with that, I plan to send it to Dr. Mack by the beginning of February. I can definitely get it to him next week. And once we have it approved by Dr. Mack, he'll send it to the curriculum committee, who I think will look it over during their meeting the third week of February, and hopefully we can send the survey out in late March, and then collect the data. And also, to make sense of this data, I will also do some literature research on the mechanisms of sleep's effect on executive function, and then we'll be working on the final product of what to do with all this data and research April and May, and then have our project done by June to present.
Can I just ask Chloe, do you happen to know when you need to get that to the curriculum committee in order for them to look at it at their meeting? Because I know that they sometimes have deadlines where they won't be able to look at it if you send it to them like that day, for example.
I think Mrs. Kevkis told me third week in February.
So they meet, the curriculum committee meets the second or third week of each month. I believe it's the third, because then the board meeting is the fourth. So she would have to get it to them. She should probably, I told her, go to Dr. McNamara the first week in February, the second at the latest, because it's got to be reviewed by our assistants to the superintendent as well, Dr. Dukevich and his team. And then they would put forth a recommendation if they feel that it's appropriate to the board, and that would go in front of the curriculum committee. Then, if they were in favor of it, they would pass it on to the full board for approval that following week. So it's a bit of a process.
Okay, that was sort of what I figured, and I just wanted to make sure, Chloe, that you were aware of that you probably had to get it in a little sooner than just whatever the deadline for the meeting is.
And we also discussed if for some reason there's like a snag, something happens with the survey, it's not approved for whatever reason, we discussed a plan B too. So, we have another option if that happens. Chloe, do you want to say what that would be, or?
Yeah, I think the plan B that we went over is to do literature research and present on just research already done and present it to how sleep affects mental health and also just proper sleep hygiene and stuff.
I think part of what we had discussed, please excuse my voice, I have COVID, which is why my camera's not, I've been home for a few days now. But I think part of what we discussed was, the difficulty sometimes in parsing out the results of the survey to directly tie it to mental health, and how hard that can be and challenging, because there are so many secondary factors to take into account. And so, we said to Chloe, let's take a look at the questions and see how we can rework them, and then also take a look at the results to see, hey, can we really make those ties, or is it something that would lead us to another step in another investigation that will eventually get us where we want to go.
And then for Bicycle Project, the main thing was basically getting information to see what data the township has, which essentially is locations of bike racks at the parks, but really not much information about locations within the town. So we I suggested to Finn a certain area, because I don't want him trekking all over the township, but a certain area of the downtown to kind of take a look and see what is available at those locations, like at the train station, in the square, et cetera. And he's also, and you can speak further, Finn. I don't want to take all the.
Sure. So, as mentioned, there wasn't much information within the township, so a lot of that will have to come from kind of our own assessment. So this past weekend, I began that assessment of kind of the downtown area, looking for larger bike racks, and then also single metal kind of like spikes where bikes can also be placed. And so obviously with the snow, that was kind of I wasn't able to continue, but I will plan to do so. And then along with that assessment, there will also be hopefully research looking at other areas, specifically college towns. I've noted in my own research have had a lot of success with their bike availability and safety measures. So in that research, I hope to find policies or goals that we can look forward to, and that will also be incorporated in the presentation as possible opportunities for other safety and availability measures beyond what we have at the moment.
To what extent do you intend to incorporate any information from the commercial bike sharing organizations that have flourished in the last couple of decades through cities that have committed to being bike friendly?
Yes, so as for bike sharing, I know a lot of information can be reached through Indigo, which we've already had, that communication has already been made, and in that we'll get more information, and that will, yes, you're correct, that will be included in the presentation.
All right, anything else on student intern projects? All right, and with that, we will go on to new business, and the first item under new business is Board of Commissioners updates from Maggie.
Yeah, I'm not sure I have any new business, but I can give you some old business and updates. Just wanted everyone to know, and if you get a chance, go to the Township website and look at the official announcement of the launch of the Community Support Unit, which was on January 8th. And there will be a presentation as well to the Board of Commissioners in February. So I think it's the 12th. Do you know? I think it's the 12th. So we're very excited about it. 4 police officers and the social worker are working together with Sergeant Lunger, and seems to be doing well, but we'll get some sort of first data, if you will, at the Board of Commissioners meeting, and hear from them as well. So I thought that was pretty exciting. The other thing, you guys will groan, but on the also the February 12th Board of Commissioners meeting, there will be a discussion of a new ordinance of dogs on leash at the, not the Willows, at Skunk Hollow Trails. Interestingly, one of the ideas that came out of the Parks and Recreation Committee, and last time I reported to you, they hadn't really given us an official recommendation. They had given us a lot of good ideas, but they hadn't just, put their weight on one. What they finally came up with is to give people that are either afraid of dogs or just don't want to be jumped on by a dog or whatever, some time with dogs on leash from noon to the park closing on Saturdays and Sundays, and otherwise continue the status quo of dogs under control, off leash on the trails. There'll be a good discussion of it at the Board of Commissioners meeting on the 12th, so we'll see where that goes. Those are my updates for this meeting.
Thank you, and I will echo what Maggie said about one thing, which is that the police department did put up on the Township YouTube page a short, it's just under 3-minute video introducing the, what's the official title of
the Community Support Unit, the CSU.
So that is up on the Township website. I can put a link to it in the minutes, and then we'll also, encourage everyone to go there and check it out.
Yeah, there's a good description on the website.
Yeah. And she also appears in the video to introduce herself. And does anybody have anything else about the commissioners? All right, so we'll move on to school board update.
I should add that I've been getting alerts from the township about the warming stations and charging stations. And we've had a lot of comment from public participation about the importance of the township contributing to protecting vulnerable citizens from climate change in the summer. But the intensity and severity of storms is also a factor, and I'm grateful to live in a township that has the kind of foresight to have warming and charging stations, cooling stations in the summer, and a CDU, is that the new unit? CSU, I'm sorry, CSU, that it is really a privilege to live in a township that considers these things and the safety and health of its citizens. So thank you to the township, thank you to our police department. Just my thoughts.
Thank you. And with that, we will go on to Paniota for school board updates.
All right, well, I will be very brief, but COVID is definitely back. I can confirm that part. We're seeing a little spattering of everything, and I'll try to break it down by school because they all were a little different this month. I think that Ithan saw a rise in some COVID cases, flu cases, and RSV, which I think are the big three that we've been talking about. Some stomach bugs and sinus complaints, but those big three for the most part. Radnor Elementary rather, is really winning the prize because they really have not had many fevers, no reported COVID, flu, or RSV, so I'm probably jinxing them by saying that. The high school has a lot of upper respiratory, sore throat with some COVID, stomach, but they haven't run across the flu yet or RSV. Wes and RMS were very similar. The middle school rather, Wayne Elementary and the middle school. Random respiratory infections, some stomach bugs along the way. All of those have kind of slowed down since December. Wayne has had one case of COVID and one case of the flu. Radnor has not had, the middle school has not had any to date. And I think outside of one other brief announcement, that just as I announced it for the high school, because I do think it's such a wonderful program for mental and physical health, Radnor Middle School will be hosting Speak Up this month on January 23rd. Students, parents, families are all encouraged to attend along with teachers and staff. It really presents an opportunity for those open and honest conversations that really do need to take place. So I would just strongly promote that as well. And that's it. Thank you.
Can I jump in behind what PT said, because something really important about what you said. It's next to impossible to know exactly what's going on with COVID immediately around us because there is nobody collecting good data. The only real data that we have are hospitalization data, and that just is a reflection of the fact that if you're going into the hospital, you're going to get a COVID test. And it doesn't really tell us anything about either community prevalence or what disease is being caused by the virus. But against hospitalizations, it can be said that the rate of admission into ICUs is probably 10% what it was at the peak of the Delta wave, and the rate of fatality against hospital admissions and ICU admissions is also much lower, which could give you some relief. The best way that people have been tracking, not the best, the way that people have been tracking the amount of virus has been through wastewater. And for those of you that are COVID junkies and follow it closely, wastewater has become very problematic because although it is a sensitive measure of the number of viral particles in the wastewater in the community, it turns out that the JN1, which is now the 60% variant, having supplanted the BBs, probably will become a new name virus if it continues. It turns out it causes gastrointestinal disease at a rate many-fold the gastrointestinal disease that was seen in previous strains, and as a consequence, the amount of viral shedding into the wastewater per viral infection is dramatically higher. So we really can't use wastewater as a quantification of virus. I would just make the assumption that it's out there because it is. and take precautions appropriate for you and your family.
All right. And then I'll just close out the school board update by, I think I can speak on behalf of the whole board on this, Panayoto. We all hope you get well soon.
Thanks for joining us, despite the fact there's a
Yes.
frog in your throat.
It's actually much better than we had it 3 years ago, that's for sure.
Yeah. And with that, the only other thing under new business was that the meeting schedule for the rest of the year was sent out along with the minutes, so everybody please make a note of that. I am going to try to take a look, since the township calendar for the whole year is up now, and see whether there are any alternate days that may work for people, because my sense is that the board is generally not happy with the kind of constant alternating in terms of managing their schedules. There's no guarantees about that, because, the township calendar is what it is, and, we can't ask any other boards to move their meetings to accommodate us. But I will take a look and see what I can find and present any options that I am able to find to the rest of the board for consideration on that. And with that, we will go to public participation. I don't know that we're going to have any, because I think the main sort of public thing that we have for tonight is going to be the presentation. I do have one resident who emailed me and asked if I could share some comments from her, and since we're under time, I'm going to take the liberty to do that. So it's from our favorite commenter, Sarah Pilling, and she wanted us to be aware with the year, we're officially have the complete year of 2023 done with now, was officially the hottest year on record. We are now 0.4 degrees below the 1.5 degrees that we allowed as the upper limit in terms of warming. 2024 is very likely to be even hotter, and therefore we need to begin now to plan for this summer. And I will note that now is in all capitals. So since she can't be here in person, I want to make sure that that emphasis is clear. And, because that kind of planning doesn't happen overnight. Ideally, we should have cooling centers that operate into the evenings, and she is then making some suggestions in terms of possibly some of the churches in the area, as well as the township reaching out to some of those kind of community areas for for support, and also whether for that kind of a public service, if there's some resistance, whether it would help if the township offered to reimburse for electricity used on the days that any of those, in other words, if they volunteer to allow it to be a cooling center for that day, would the township be willing to reimburse that center for that day for their electricity usage? So that was, I think, the only public comment, unless we have anybody else who wants to make a public comment. All right. Anything else from the rest of the board? All right. Well, with that, I will entertain a motion to adjourn. We are scheduled to go into a special presentation of the Board of Health immediately after the, oh, sorry, David, do you have something? Oh, okay. We are scheduled to go into a special presentation of the Board of Health immediately after this meeting for the ease of the use of technology. We're just going to keep the current live stream going, so it's not going to switch over to a different live stream, but it is technically a separate meeting. So after I gavel the meeting closed, since we said we're going to start at 6:30 and allowing that some people may be running a little behind because of weather, we can kind of come back in to start the special presentation closer to 6:30, maybe 6:35, when we sort of said it would start. And then, so with that, I'll take a motion to adjourn this meeting that we're in right now.
Move to adjourn the meeting of the Board of Health.
I second the motion.
All right. And it definitely is. And with that, we, like I said, at around 6:30, 6:35, we'll reconvene in here to begin the special presentation.
We're going to address the people that are here. I'm going to put the mannequin here, if I can just pull this. Honestly, rather than everybody being spread out, because this podium is immovable.
So it can rotate. Let me get him because like all the wires are attached, and then we will get in major trouble.
Okay. I want him to get. Just set it right there. I've been giving it out like candy.
So who's the main speaker?
Sarah, I'd like.
Hey Sarah.
You.
This is Ian Myers, the IT. He knows how to run anything. So tell him what your objectives are, and he can try and meet them.
Okay, great. Thank you so much. All right. So.
We have this table, we also have other tables. That's fine, we have a handheld. We do have like a live stream going out.
Where do I?
Not this one.
My slideshow.
Do you have a,
I have my computer, but I do also have.
sure.
I can just plug my computer in. Yeah. Kensington, in this weather, okay. But you didn't plow anything.
We're just gonna switch them.
Yeah, I think that's fine, and I can just make an announcement so anybody who's on the live stream.
It's just the agenda's
Oh,
So we're gonna shut this down because we're live streaming, and we're just gonna switch over to your laptop.
I have that slide.
You have this slide too?
Yeah, I have it, last thing on.
Oh, okay, perfect. Great. Just good. That's the social worker one, I think.
Yeah.
So I just sounded the Zoom if you want to send out.
Okay.
Message to those on there.
Okay.
I have to plug this in too?
No, this was so many wires here. You should be good with the HDMI. Let me check on my end just to make sure everything's coming up.
And then as far as the mannequin, setting that up?
Yeah, we can move this table wherever you
Yeah, I think a lot of people might have thought it might be canceled. You know, even my
Yeah,
my
I did.
father-in-law was like, "Are you sure they're
Yeah,
having
so
it?"
I did ask Adam to send out an email to everybody saying that it was still in person, because I know the schools got canceled.
Yeah.
But that was, 8 a.m. this morning, this is 6:30 at night. It was, I mean, granted, the roads are still plenty icy,
Yeah.
especially the, little side ones, but, so, we'll see. But I think I saw our state rep is here, so that's very
Oh, that's cool.
Yes, I don't know if you know Lisa Brasky, but she just came in, so. Yes, that's her.
Stop. Adam's not even here.
Hi, Sarah. I don't know, we haven't actually met. I'm Alex. I was talking to Adam,
Oh.
getting a lot of this set up, so we're
Thank
thrilled to
you.
have you here.
Thank you so much for your help with that.
If you have anybody that you want to encourage, I think she just needed to go to the bathroom because we just got done with our long meeting, so I think
Oh, okay.
she may have needed to go to the bathroom or grab a drink or something.
Okay.
If you do have anybody that you
And that table's good for you guys? You want the bigger one?
Yeah, I'm gonna slide it over just so we can put the mannequin and some Narcan on it.
Yeah, wherever you want to move that.
we're here to help you guys get the message out.
Our youngest resident, Steph Hackett. Well, congratulations.
And then where are you gonna do the rescue position?
Video. Oh, the parents died.
That sucks. Okay, you're nervous, you're nervous.
Also, Anthony would be rolling around the floor if that was the case.
No, for sure. Aunt, you ready to do rescue? No, I don't like it over there.
Yeah, the county's giving us
That's good. Do you have enough to do like a key Savage Sisters? Hello, mother. I'm really glad that Savage showed up. I know. Said I'm really glad that Savage showed up. We out here. We are obedient. Did you notice who's not here? Did you notice anybody missing? Oh, interesting that you should mention that. Can you call me? He also said. Adam.
And like I have two if you need two.
She's gonna need one, but we can, if you want.
Yeah, we can just
pass
pass it back and forth. Yeah, we don't talk at the same time.
So just on and off with the switch whenever you're ready. Unfortunately, yes, or else we're not going to be able to hear you guys. You can also use this if you prefer.
All right, cool.
I'll just leave it up here for you guys.
So really quickly,
Yeah. We can exit it. Or just unplug it.
it doesn't matter.
Okay.
I pulled everything from technology strips out.
Okay.
I wanted to look at it. Are we starting immediately?
No, just select.
So what I was going to do is I was going to introduce Kiki to tell kind of her story a little
Yeah.
bit and why, we're all here. And then she's going to talk a little bit about her story. I think here also is something else to speak a little bit. Okay. So.
Okay,
Okay.
I'll let her.
Max
Okay.
here.
Okay. All right. So I guess we're going to get started now. Thank you, everybody, for coming through what ended up being some not so great weather conditions, unfortunately. But so this is our very first. I think we never even really decided what we're officially calling it, did we, Maggie? A special presentation of the Board of Health or a sponsored activity of the Board of Health. But this is the first one that we're doing, and we already have more people than I think have ever showed up to a regular Board of Health meeting. So it's fantastic, nonetheless. And that's with the weather conditions. So I can't believe it's this many years, but about 20 years ago at this point, there was a young Greek boy sitting in the second grade Sunday school classroom of a couple of very wonderful Sunday school teachers. Just so happened they were the only other people at the same church that had a child attending Radnor schools in the same grade as him. And like I said, quite a few years later, I joined the Board of Health, and we had some vacancies during COVID. And at the time, we did not have any nurses on our board, which was something that I thought was missing. So when I reached out to Kiki to see if she would be interested in joining our board, I, of course, cited the fact that she was a nurse. But I also reminded her that in addition to being a nurse, she's not just one of our most important frontline healthcare workers, she's also one of our most important pre-frontline healthcare workers because she's a mother. These are the people that put on Band-Aids and take your temperatures before you even get to the waiting room at the doctor's office. I'm also very honored to have my own mother here tonight, who's also a former chair of the Radnor Board of Health. So I knew that she had an important story to tell because a couple of years back, my dad let me know that he was going to a funeral at our church and that it was for her son, Michael. At the time, I was 27, and I had never been to a funeral for anybody younger than myself. And the strength that Kiki has shown in taking on this fight to make sure that no other mothers have to deal with the same thing is so incredible, and we're so lucky to have her on our board. So I'm going to, without any further ado, introduce her to come up and speak to you a little bit about why we're all here tonight. And yeah, Kiki, do you want to come up?
Thank you, Alex. Good evening, and on behalf of myself and other members of the Radnor Board of Health, welcome, and thank you for braving the storm coming out tonight. The focus of this evening's presentation will be an information session about opioids and overdose reversal. That demonstration will follow. In addition to being a Radnor Board of Health member, I am a Radnor school nurse, a Radnor resident of 28 years, and first and foremost, the mother of 4 Radnor School District alumni. All my children were Radnor High School graduates that went on to complete graduate degrees. Sadly, my youngest child, Michael, was unable to complete his Doctor of Physical Therapy degree as his life was tragically cut short by a fentanyl poisoning in 2019 at the prime age of 25. Michael was a Radnor athlete, band member, honor student, and lifeguard who was very popular and loved by many. The loss of this magnitude shatters my family's hearts and rocks our souls in seismic proportions every day as we see Michael in our memories everywhere. From the brilliant smile that lights up a room, the enormous hug that engulfs your heart, the unbridled passion of riding a huge wave, the elation of the Eagles' Super Bowl win to the joyful tunes of his piano, drums, and harmonica that now sit in deafening silence. The visceral pain of Michael's absence at every life event celebration is excruciating. Our country is experiencing the worst drug crisis in history. In fact, someone in the U.S. will die of an overdose in the next 5 minutes before I finish speaking. Moreover, Kensington is a main hub of overdose that has received widespread attention. While we like to believe that we're immune to this in our mainline community, make no mistake, Kensington is just a text and an Uber ride away. And like any other disease, addiction does not discriminate between race, zip code, or gender, affecting everyone. We, as a community, and as my family members in particular, are the faces of addiction. We are committed to the prevention of any other family suffering the devastation that substance use disorder causes through public service and our family's nonprofit foundation that we created in Michael's honor, the Michael Carianis Waves to Wellness Foundation. We do this not so much in memory, but in honor of Michael's life, so that those memories are brought to life once more. Needless to say, I am thrilled that the Radnor Board of Health is hosting this important event from which every Radnor community member may benefit. Now I would like to turn the program over to Sarah from Savage Sisters, who will present our topic and demonstration.
Hi, guys. My name is Sarah Laurel. I'm the founder and executive director of Savage Sisters. I'll be presenting tonight with Mel.
Hi.
Okay. Thank you, Kiki, for that introduction. We've worked with Kiki for years, and she's helped a lot of our residents and a lot of our friends in Kensington through funding and different outreach events that she's attended. So super grateful for this opportunity, and it's lovely to see you. We're going to talk about a couple of things today. We're going to tell a little story, talk about harm reduction and what that means, the mission of Savage Sisters. We don't call it an opioid epidemic anymore. We call it a public health crisis. The overdose crisis isn't specific to opioids anymore, and we'll get into that a little bit later in the training. We'll go over some nationwide and statewide statistics, the most up-to-date information that we have for you currently. The update on current drug supply is going to talk about something called xylazine. I don't know if you've heard of it. Xylazine, tranq dope. It is what the drug supply is now, especially in Pennsylvania, specifically this area. Some of the information that we're going to be showing you can be a bit triggering. There are pictures of wounds, a small clip of a 2-minute video that, again, has some wounds on it. So if you don't like to look at that stuff, turn away, walk away. I understand there will be another warning before we get there. If you have any questions, I encourage you guys to just shout them out to me. I built this training. Me and Mel have given this training hundreds of times, and I've trained 300 people, and I've trained 3 people. So you're not going to knock me off my block. There's no such thing as a stupid question, and we're going to be talking about a lot of information that you may have never heard before. So please shout those questions out, raise your hand, and we'll do the best that we can to give you the most up-to-date information possible. Before we get into all of that good stuff, Flanagan is going to come up here and talk about some legal stuff that is going to be helpful for the community. I think this is super important. Typically, we talk about this a little bit later on in the training, but I wanted to give the Radnor police officers that are allowing us this space time to let you guys know a little bit about this law and how it protects individuals, especially when responding to overdoses.
Thank you. Real honor to be here, and one of the things they just asked us to speak about, and I think it's important for people to understand, is the Good Samaritan Act. A lot of people are a little bit aware of it from like CPR and helping people who are choking, which is one of the premises how it started. However, David's Law, which is a family that has a real story and a loss of life due to drug addiction and an overdose, was able to get this to also incorporate people who help during drug and alcohol issues, so that you can contact the police or dial 911 for an ambulance, and you are not going to be prosecuted for participating in life-saving or summoning that ambulance, regardless of the circumstances that are going on. So it is very important to understand that if you are a neighbor, friend, or loved one, that you could, and also encourage those people that you can learn how to administer Narcan and help save a life based on a critical situation going on for an individual, and not be prosecuted or get wrapped up in maybe some of the other things that are going on. So just wanted to share that small clip. They felt it was important. Kiki, thank you for inviting us. And that's it. We're always available to answer any questions about that later if you do have one.
All right, so a little bit of history of Savage Sisters and how we started. Our mission is to attack addiction ferociously with radical love through connection, and we do that in 3 different ways, which I will get into. I was born and raised in South Philly. I went to Radnor High School for 3 years. I was a cheerleader, believe it or not. And I worked for a pretty well-known hotel chain, got carpal tunnel, got prescribed a prescription for opioids, and that led to a harrowing heroin disease, addiction, whatever you want to call it. I was homeless in Kensington. I've been arrested multiple times, been to jail, been to treatment 28 times, and finally ended up in a wheelchair after experiencing a trauma in Kensington, and decided that after being brokered through many unsafe houses and programs, I was going to start my own program. Originally, I wanted to start one house for women that was safe, and today we have 11 houses throughout the state. All of our houses get free trauma therapy, kickboxing, and yoga as modalities of healing. We have a drop-in center in Kensington where we do outreach. We do wound care and showers for those experiencing homelessness and substance use disorder. And we do nationwide trainings on drug trends, harm reduction, and overdose reversal. So that's a little bit of my background. My entire team, there's 15 of us. We all have lived experience. We are recovering from homelessness and substance use disorder, minus 2. 2 of them actually have degrees and masters and stuff. But the rest of us use our lived experience to really implement and practice harm reduction on the ground. And we've been significantly effective at that. I don't know how, I don't know why, but it just happened very organically. And I want to introduce Melanie Bettis. She's our program director, and she's going to just give you a little bit of her story.
All right, guys. So I am Mel. I'm also a person in long-term recovery. I had been to treatment 17 times, also in jail. I tried many different recovery houses, and I actually came to Savage Sisters through the housing program. And it was unlike anything I had ever tried before because, like Sarah mentioned, they offered kickboxing, yoga, trauma therapy, something that I had never done. I came from a very 12-step background. That was the only way to get sober. And just being integrated into Savage, it kind of opened my eyes to other options, right? I started volunteering with the outreaches. At the time, it was just the once a week and the one big one every month, and I fell in love with it. I didn't know what harm reduction was. I had no idea, but it gave me a purpose. And I'm just grateful that I was able to grow with the organization and expand and oversee the drop-in center and the housing program, and be able to relate to people on that level, because whether they are on the streets or in the housing program, I've been in their shoes and I kind of know what they're going through.
Okay, so this first slide that we have here gives you the SAMHSA Googleable definition of what harm reduction is. Most individuals that we train don't know what harm reduction is. So take a picture, Google it later. I'm going to explain it in layman's terms as far as Savage Sisters goes. When I started doing harm reduction, I had no idea what I was doing. Prevention Point is a large harm reduction organization in Philadelphia. It's known as the Syringe Exchange. When I got sober and was told to go there to get Narcan, they were like, yeah, go to Prevention Point. Never knew it was called fraud prevention point, didn't know what harm reduction was. I called it the needle exchange. So when I started doing this work, I realized that a majority of individuals have absolutely no idea what this is. It is policies and programs and practices that are aimed to minimize the negative health, social, and legal consequences associated with drug use or other high-risk behaviors, so sex work and things like that. What that looks like for Savage Sisters is, number one, housing. Reducing the harm that individuals that are coming into recovery, or whatever path that looks like for them, reducing the number of harms that come to them when they are brokered in and out of unsafe programs, providing them with autonomy in the housing program and different modalities of healing. So not telling them that they have to heal in a very specific way, giving them options and saying, you actually play a part in this healing journey and we want you to choose. That's how we reduce harm through our housing program. We reduce harm through our education program by informing the community. One of the biggest things is awareness. Most people have no idea what's going on because until it hits their doorstep or it haunts their hallways, they don't understand it and they're not going to. So one of our biggest ways that we want to reduce harm is by informing the family members, the friends, and the community members of what is happening with our drug supply, which is absolutely toxic, how to respond to an overdose, or how to engage with a person who uses drugs in a safe way that is going to make them feel comfortable and be effective. The final way that we do it is through our outreach. That is practical. So that is clean syringes. It is pipes. It is sex worker kits that include mace, condoms, and lube. This is how we want to reduce harm for individuals that are absolutely going to engage in unsafe behaviors, and we want to give them the tools to reduce the risk of transmitting diseases and other consequences that are connected to those behaviors, especially when it comes to survivor sex workers. These are, again, the 8 pillars of harm reduction. If you go on the National Harm Reduction Organization website, they're going to list all of these things. In my opinion, it's a bit redundant, and it's all saying the same thing. So we simplified it, and we have the one next to it, the next slide, which is people do drugs. They always have and they always will. We need to make it safer, okay? Drug use isn't a black and white issue. You can actually use safely, and that is what we talk to our friends about. So alcohol is a drug, right? You can drink safely. You can make sure that you get home safely. You can make sure that you don't consume more than a certain amount. That is safe use. So that is part of the things that we try to do. We try to talk to our friends about using slowly, never using alone, carrying Narcan, being prepared to respond. Abstinence is an outdated, archaic, unrealistic expectation. It was the way of the world years ago, and it was taught that way for decades, but we know now that that is not the model that most individuals follow in order to get into the recovery path. So we need to understand different modalities of maintenance-assisted treatment when it comes to opioids and other substances. Be nice, don't judge, don't force. That's a huge part of the work that we do in Kensington. All of our friends that we work with during our outreach are very aware that what they are doing is unhealthy and unsafe. I've never walked up to a friend and been like, did you know you're doing dangerous drugs? And they're like, nah. They know exactly what they're doing. They're aware that it's dangerous. So I don't want to go at them with any kind of judgment, and I don't want to try to force them to do anything. Coercion when it comes to treatment is never effective, not in my eyes. We ask that you bring us to the table. People who use drugs need to be the guiding voice for these policies. Mel and I identify as a person who used drugs, right? We're in long-term recovery. So bringing us to the table and asking us how it feels, what it looks like, what it tastes like, what that recovery journey feels like, how it feels to be treated poorly throughout the system, and how we can improve in better ways. You're never going to know that if you don't bring us to the table. You can't just make assumptions about how people want to be treated. And that same thing, people who use drugs are the experts and are uniquely qualified to serve in this field. Trauma is the gateway drug. I know, like I remember hearing like marijuana, like it's sweet or alcohol, right? It's not. Every person that I ever knew when I was growing up, all high school students try drinking and they smoke weed. Not all of them are exposed to trauma. Not all of them have mental health disorders that are untreated. Not all of them have other issues like that. So we really need to look at the mental health issues and see the correlation between that and substance use disorder, misuse, and chaotic use at an early age. Be real and honest based on history and evidence. So the truth, not the myths that we want to perpetuate within our system, and when we're engaging with people who use drugs, because we want to use fear-mongering tactics. Not going to get too much into that, but that's what it is. Here.
Okay, so what is an opioid, right? So this purple little poppy flower that we have listed there, that's where all your non-synthetic opioids are going to come from. It's highly addictive narcotic. It can be very useful in a medical setting. However, these are like the most common ones, right? And you can find these in most family medicine cabinets. You have your Vicodin, your Oxycontin, morphine, and notice fentanyl is listed here. But when we're talking about this kind of fentanyl, we're not talking about illicit fentanyl, right? They can give this to cancer patients, people who are in a lot of pain. Like, it does have a good use when used correctly. Tramadol is even now considered an opioid, and it wasn't for a very long time. And they prescribed it to people and then saw that it did have negative side effects or could be addictive. And then methadone and buprenorphine, which are MAT drugs. So buprenorphine or Suboxone, it's a daily medication, right? It's now also offered as a monthly injection. It's going to bind to your opiate receptors in your brain and kind of block that. So if you were to use while on Suboxone, you're not going to feel that. You're not going to get that euphoric effect. And it curbs cravings. Same thing with Vivitrol. It binds to your blockers. It's a monthly injection, or they have a pill that you can take every day called naltrexone. And it's going to curb cravings and then also not allow your body to feel that euphoria from using an opioid. Methadone is a little bit more high barrier. It's a daily medication. You usually have to go somewhere every day to receive that medication. However, with the xylazine that we're going to talk about a little bit later, it's super beneficial in treating xylazine withdrawal. The only downside to methadone is that you are still able to use an opioid on top of it. So why heroin or fentanyl or xylazine, right? People ask me this question all the time. Me and Sarah have done media interviews, and they say, why would anybody choose to put this in your body? I didn't wake up one day and say, like, oh, I want to be a heroin addict, or I want to consume xylazine, right? I don't want to put an animal-grade tranquilizer into my body. It's cheaper. So people who misuse pain pills are 19 times more likely to switch into heroin, fentanyl, or xylazine. And I've never gone up to a drug dealer and kind of asked, hey, what's in this? It doesn't come with ingredients on the back of the bag, right? You're just at the mercy of the criminal drug market. So we're going to put into our body whatever is available to us, especially when you have substance use disorder and you need that substance to feel better. So this is just kind of showing you what different types of heroin look like. So the first picture, the brown, that's like what real heroin used to look like back in the day. It's gone. It doesn't exist anymore, at least not in Philadelphia or any surrounding areas. The white is kind of what you're going to see in the Kensington area because it's usually, now cut with fentanyl or xylazine. The bottom picture is black tar. That is more of a West Coast thing. You're not going to see that on the East Coast. It doesn't really look too much like that. It's kind of like if a piece of like melted tire, super sticky. The picture on the right, however, so you can see that first vial has heroin in it. And that is how much heroin a typical person would need to overdose. Now, if you look at the two vials next to it that contain carfentanil and fentanyl, you can see the amount is significantly smaller, right? And that's how much somebody would need to overdose. And the bottom picture is just kind of showing you pressed pills and that are made with fentanyl and how they can look almost identical to a pharmaceutical opiate. All right, Sarah, you want to take this?
She's a little nervous about this one because we get a lot of arguments. So I hope I do get arguments with this one. Myths about fentanyl. Number one, first myth, you can overdose by touching fentanyl. No, you can't. Absolutely impossible. Doesn't work that way. That's not how fentanyl is consumed. Fentanyl powder can be inhaled through the air. Nope, can't happen. Not a real thing. And I'll give you an example in a moment. Narcan can't reverse a fentanyl overdose. Not true again. The reason that we are seeing articles and news clips and all these different things across the country where people are saying it's Narcan-resistant fentanyl is because it's not fentanyl. It's xylazine. It's not an opioid. And they're not testing the drug supply, and they're not informing the public of what is actually going on. Now, we're going to go backdate to 2016 when the DEA typed up a half a page and made a disclaimer, and then they sent that across the United States to a bunch of different police forces. And by a bunch, I mean all of them. And they made a general statement that you could potentially overdose from touching or inhaling or coming near fentanyl. Immediately following that, the American Medical Association responded with a 6-page document telling them why that was absolutely incorrect, would not actually happen. You could stand, and I quote the American Medical Association, "You can stand in a wind tunnel for over 200 hours with fentanyl blowing in your direction and you would not experience a fatal overdose." That is not how fentanyl gets into your system and causes fatal overdoses. So, the videos of individuals saying he came in contact with it, needed to be Narcaned. If you can Narcan yourself, you're not overdosing. Okay? If you're awake, if you don't show signs of an overdose, which we will go over later on, you are not experiencing an overdose. You are having a panic attack. The reason that we think it is very important that we talk about this is do not be afraid to respond to an overdose. Do not say, oh, I saw that one clip of that guy and it looked like he breathed in fentanyl while passing a person and he must have experienced an overdose. Incorrect. Always respond to an overdose. You can absolutely not experience an overdose when responding to one. It's not going to get absorbed through the skin. That's not how fentanyl works, and it cannot be inhaled through the air. Next up on the list, fentanyl is in marijuana and CBD gummies. Absolutely not. Fentanyl, number one, will burn away when direct heat is applied. What do you mean? I've seen people smoke fentanyl and heroin. Yes, direct heat is not applied. It's tinfoil. They do the flame underneath of it, and if they mess it up and keep the flame on top of it, all of it burns away. So if you're smoking marijuana or a substance similar to it and you apply direct heat, you will burn away any kind of chemical that would cause a potential overdose. Finally, dealers are lacing candy with fentanyl. No, they're not. This makes absolutely no sense. Nobody would do that. That makes no sense. I will explain one thing. Drug dealers don't have the cleanest areas where they bag up their stuff. They're not dealing, let's say the drug dealer sells fentanyl, cocaine, and marijuana. In between bagging up his cocaine and marijuana, he's not sanitizing the table in between. So there have been very, very few cases where cross-contamination could take place. However, by the time you apply direct heat to that marijuana, it would burn it away, and they are not experiencing a marijuana-laced fentanyl overdose. They are just uncomfortable because of stigma to actually openly disclose that they are also using fentanyl. That is most likely the case. Does anybody have any questions about any of these things? Go. We're going to leave that. I can't hear you because you were late. What did you say? There's never been a confirmed case of CBD. Okay, so he said something about heat and CBD gummies. There's never been a confirmed case of CBD gummies having fentanyl in them. That's never been confirmed. There was a myth about it, but it was never proven. Again, these kinds of stories happen when younger individuals get caught with certain substances in their urine or their drug screen, and they are afraid to self-admit that they are using different substances. You are not going to get a CBD gummy with fentanyl in it, I promise. Okay, so this is an interesting chart, and we're going to try and get through it quickly because for time's sake. We have pharmaceutical opioids, which like Percocets, Oxycontins, et cetera. That's the black line there. And then you'll see when like the DEA came in and they were like, we got to get control over this. We got to, send the troops in, shut down the pill mills and blah, blah, blah. So you see that line drop a little bit. And then you see the heroin line, right? So everybody started kind of using heroin back in 2010. You see that spike go up. And then after we kind of shut down the pill mills, the DEA came back in and they were like, we got to get control of the heroin. Okay, everybody's doing heroin. We really got to focus on this opioid crisis. And then you see the blue line. That blue line is fentanyl. So as we started focusing on the prescribers, the pharmaceutical opioids, and heroin, which was coming in across the borders, the criminal drug market decided that they were going to find a cheaper, more lethal, more potent substance, and they were going to put that in the drug supply. And as we see, that number goes up. Those are number of people dying. So as those numbers where we heavily focused on pharmaceuticals and heroin kind of drop, you see that fentanyl line go all the way up. We show this to explain that no matter what we do, when we hyper-focus on one substance, the criminal drug market is always 10 steps ahead of us, finding a new substance that is going to be more lethal and potent that they can adulterate the supply with in order to meet the demands of the public. Now, this is fentanyl. What we're going to show you guys in 5 years is polychemical substances, also known as xylazine. Because as we hyper-focused on fentanyl for the past 10 years, we now saw the criminal drug market respond with a new substance, which is more lethal, more potent, has a lot more public health consequences, and is the new drug of choice in this area. Okay. So this is 2022. We had 5,143 deaths. I did put a little note up there for Delaware County. Received over 2,000 911 overdose calls in 2022. I think this number is hilarious. 11,700 people have diagnosed that they have a drug use disorder. Those are people that are admitting it on paper. Okay, a lot of individuals will never admit to that, so that is a very low number. And Pennsylvania experienced more than 5,000 deaths. I think this is our 3rd year in a row with that. And Delco, you guys are in the top 10. So these are the demographics that we got from the Department of Health. This year, actually, they were the most up-to-date, just showing different, based on sex, age group, race, and ethnicity. There is a huge jump in, there's a 13% increase for Black Americans experiencing fatal overdoses. This is xylazine. And this is the first time it's ever been on anything that the Department of Drugs and Alcohol actually released to the public. These are the counties where they have shown xylazine has been contributing to the death of an individual experiencing an overdose. Now, I just want to point out, when I met with the Department of Drugs and Alcohol, I asked what percentage of individuals, when they experienced a fatal overdose, were being tested for xylazine, and they said less than 10%. So the fact that this is what we're showing for 2022 is incredible. All right, well, now I'm going to be on here. Do you want to? Okay, xylazine. Has anybody heard of xylazine or tranq? Yes, okay, I love that. Thank you. It's going to make it a little easier. It's basically a benzo for like a cat or a cow. It's an animal-grade tranquilizer. It's used to put animals down as small as a cat, as big as a cow. The same way that when you go to the hospital to get a surgery, you go in, they put you under, you're asleep for 30 minutes, and then when you wake up, you're super groggy. Somebody has to drive you home. That's what it does to animals, okay? It's not safe for human consumption. It has been classified as an emerging threat through the Office of National Drug Control Policy this year. Shapiro did actually make it illegal this year. It's used to adulterate heroin and fentanyl. Popped up in the supply in the early 2000s in Puerto Rico. It came in and it saw its way out. We saw it pop up in the Philadelphia drug supply about 8 years ago. And as of last year, it is in 99% of the quote-unquote dope supply. Just so you guys understand, because I know that there's a separation between Kensington's not Delco. Anybody that uses drugs that lives in Delco is getting it from Philadelphia, okay? Because there's nobody there's no cartel in Delco. So if you're using drugs, you're going to Philly. And it doesn't matter if it's Northwest, South, Kensington, doesn't matter. It's all the same stuff. It's an alpha-2 agonist, very similar to clonidine, which we'll talk about later on. It has heavy sedative effects, which can be very dangerous for the individuals consuming it. The best thing that I can say is, as an alpha-2 agonist, other drugs that are alpha-2 agonists that have similar withdrawal signs, so if you think about like benzos, Xanax, Klonopin, Valium. If you think about alcohol, if you think about barbiturates, the stuff that Marilyn Monroe died from, those things have a binding affinity to the alpha-2, G receptor. Thanks, Mom. Way to look out. Now, so reducing harm for xylazine is incredibly difficult for us. I'm just going to tell you, we've been on the front lines of this for about 7 years in the streets of Kensington. We saw it coming out in wounds. We didn't know what was going on. Our friends looked really lethargic. So why would anybody put xylazine in the drug supply? Remember that slide where we looked at and we saw pharmaceutical opioids, and then we saw heroin, and then we saw fentanyl kind of take a spike? For an individual who uses drugs like that, when you do heroin, you are well, or not dope sick. I don't typically like that word, but for training purposes, you don't get dope sick for 24 to 36 hours, depending on how good or how potent the dope is, right? So if I do my heroin, I have 24 to 36 hours before I'm going to be physically unwell. With the introduction of fentanyl, that window got smaller. So I went from having 24 to 36 hours down to having 18 hours. So what happens is when your customers have to use more frequently, they're going to complain. So they're like, we don't like this. Yes, it's more potent, but it wears off quicker. I'm getting sicker quicker. Drug dealers don't want their clientele getting sicker quicker. So they would try and use different substances to adulterate the supply to give it legs, is what we call it, to extend that high, that euphoric feeling. Originally, when xylazine was adulterating the drug supply, it was giving it legs. When it's 90% opiates to 10% xylazine, it's just giving it a little bit of legs. But we've completely switched that around. It's now 1 part fentanyl to 1,000 parts xylazine. With the increase of xylazine in the dope supply, for a multitude of reasons, mainly because it's cheaper, it's $6 per kilo of xylazine, easy to access and wasn't illegal. The criminal drug market was like, well, this is great. It's cheaper, and there's no legal consequences for it, and the kids seem to love it. So they continuously added that in, and as we saw that increase within our drug supply, we saw different things happening to our friends. So the skin wounds, I would say I'm going to talk about first. They started out as smallpox. That was the most visible. We knew that they were sleepier. We knew that they were had extended periods of being unconscious. But it was when the wounds started to appear that we really started to pay attention. There's a lot of risks because the acute poisoning for xylazine, you can overdose. It reduces your level of consciousness, death. I'm sure individuals have seen the Zombieland stuff that goes on in Kensington. There is a reason for that very lethargic look, for that coma-like state. That is the xylazine. So we always suggest don't use alone. Making sure that you let somebody know that you're going to be consuming. Go slow. The prolonged sedation can cause additional issues. So deep vein thrombosis, pressure ulcers, nerve, muscle, soft tissue injuries. We spend a lot of time in Kensington moving individuals into safer positions because being in one position for a prolonged period of time causes a lot of problems. Checking on your friends every couple of hours and adding padding underneath of them depending on where they're seated. Especially when you're talking about women who are unhoused in the streets of Kensington that are completely sedated for several hours, they are at higher risk for assault as well. Now the skin wounds, we'll get into in a minute. So Savage Sisters does one other thing when we do harm reduction. We do statewide drug checking. And this is a really cool thing that we get to do. We love this part of the job. We get drug samples from all the different corners in Philadelphia, and we get to send it to a lab, and we get a scientist that gets to reach back out to us and say, hey guys, this is what's in the drugs. This is not normal for every state, but we work very closely with the Department of Health, and they began this initiative in 2017. And so we were able to gather all of these, all this data over the past 6 years, with their help, and a lab that's in Pennsylvania. So this is what we're looking at. 4 parts fentanyl, 45 parts xylazine, 6 parts fentanyl, 43 parts xylazine, 7 parts fentanyl, 54 parts xylazine, et cetera. And there at the bottom, 1 part fentanyl, 73 parts xylazine. You see some other stuff. There's lidocaine in there. Additionally, lidocaine, if in large amounts, can cause seizures. So a lot of times when we respond to the overdoses, our friends will have a seizure, which can be complicating. Okay, go ahead. No. I will tell you right now, there are 0 human case studies on xylazine and the effects on the body, the brain, or anything. Period. Full stop. We're working on it. We've been working on it for 7 years.
We're
The following can be a little bit difficult to look at. I will say this. We don't call it a zombie flesh-eating drug. It is not a zombie flesh-eating drug. What xylazine does is it causes vasoconstriction. Constriction means smaller, dilation means bigger. So when you are consuming xylazine, it is a vasoconstrictor, which means your cells are going to get a little bit smaller, less oxygen is going to get to them, which means it's harder for your wounds to heal. Anytime they get a basic nick or a cut, if they scrape their legs on the wall, whatever happens, less oxygen gets to it. An unscabbed wound is an ulcer. That's really all it is. It's nothing super fancy. It's not super hectic. Depending on your body, your nutrition, other autoimmune disorders that you may not be treating, your body's ability to heal a basic cut or scrape is being strongly limited by consuming a vasoconstrictor. So once those ulcers don't heal, they grow and they get infected, especially if you're unhoused. This is a 2-minute clip of Chloe. She is a nurse at the Philadelphia Prison System who volunteers with Savage Sisters when we do street outreach. We allow people to come into our storefront where they have privacy to get wound care, but we also go out to them because a lot of individuals will not come to our storefront. This is a bit graphic, but it's just to show you what we're seeing. You might not see it on somebody when you're walking past them, but when they pull back their sleeve, it's very obvious.
Honey, what's your name? I'm Chloe. Nice to meet you. So do you mind if I take your whole shoe off so I can see what your whole foot looks like? Yeah, I wish. I'm not a doctor, so I don't like to say you have to. You don't. It looks like you have cellulitis in your legs, which is an infection underneath the skin. You should probably go to a hospital, get it checked out before it gets worse. See how it's hard? It's called necrotic. The tissue underneath is dead. So right here where you see this green stuff coming out, that's because you have pus. It's infected. Ooh, babe. I want you to take your whole video. I want to see your whole arm. You see the white? That's tendons. So that's not just your skin. That's down to the bone of your tendon. What's gonna happen is it's just gonna turn black. Babe, this is.
All right, so they start out looking like this, like a possible scratch or a picking scab or something like that, and then they progress on, and we're going to show you guys a couple of more photos just to show you the progression. One is infected, one is not. That black tissue there is necrotic, and the unfortunate thing is we don't have wound debridement street side, and until that wound is debrided, it is not going to heal. Fortunately for our friend there, that pink-looking tissue in the inside of it doesn't actually hurt anymore. But for Tiff, who's on the other side that's infected, that does actually hurt, obviously. A couple of other things were, listen, the next 2 slides are going to be gross to look at. I understand that, okay? So bear with me and we'll get through them super quick. We started working on this xylazine situation years ago, and I was banging the door and saying, please, 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 you know, help us with xylazine. And I was asking for people to test for xylazine. I found out that it didn't exist. And then I was like, we need updated withdrawal protocols. We need updated wound care protocols. We need updated reversal protocols. And a doctor sat me down and said, you're not going to get any of that stuff right now because it's going to take years for that to happen. Until there's human case studies on it, until it's in more states, until it's affecting a larger number of individuals, you're basically kind of not going to get the help that you need. So we changed our narrative and we realized that one of the best things that we could offer our friends was running water. If we could just give them a shower and access to a toilet and clean wound care supplies, that
their body's ability to actually heal was there. They just needed running water. So that was what we did here. Nick came in, his arm was open, it was gaping, it was infected. We made sure he took his meds every day. He would come in to the storefront and he'd be like, "What's up?" And I'd be like, "Take your antibiotics," and he would take them. He would take a shower, he would get the nurse to wrap it. It's now closed, his wound is healed. So we were trying to, follow and track basically the medical outcomes of individuals and their wounds as they had access to public health services, to ask the city for those things. If you're not going to give us all the medical things that we need right away, because I understand that's a slow process, give us more showers and toilets. So that's Nick's arm. That girl in the middle is Steph. She's actually from Bucks County. She's a 22-year-old girl, and she's now an amputee. She lost her hand. When she went to the hospital to ask for help, they wouldn't treat her. They told her that she had to get on Suboxone in order to be treated because she was an addict, and that she wasn't allowed to have any pain relievers because she was an addict. So she left, and she continued to inject xylazine until she lost her hand. So I'm asking the community, talk about this, tell your friends about it. If you know anybody that works in the medical world, we need to inform our community. We need to be prepared for this. We need to treat the urgent need, not the important need. The urgent need is save the limb. Once we save the limb, and no offense, but give her pain medication, okay? Because it hurts to look at. Do that, make her comfortable, save the hand, then we talk about the substance use disorder. And then that's Maurice at the end. He wasn't able to gain access to regularly coming in. So that is never going to heal. We needed the wound debridement street side, which we don't have. Nurse practitioners can't even do that street side. It's dangerous to do that street side. So we really need to increase accessibility to wound debridement, because until they kind of slice around that and remove that that's not going to begin to heal properly. So we need to begin to train on that. These are individuals who inject directly into their wound site. So a lot of the work that we do with our friends, you can go to the next slide, they don't have to look at it. Don't inject into your wound site. Terrible, terrible, terrible idea. These are your wound care best care practices. We always tell our friends, wash your dirty mitts, don't touch anything with dirty hands, use gloves if you have to. This isn't going to be super relevant right now, but when we do these trainings for medical professionals and individuals doing street-based outreach and encampments and things like that, this comes in really handy. Ensuring that individuals have access to clean supplies to change and dress those wounds, and not to use certain things. These wounds are a little bit different. They kind of look like a burn. They're not typical. So there's a different way to treat them, and we want to make sure that we're updating that so individuals know how to not do any harm, so that we can increase the wound healing process. These are recommendations. We don't have any human studies on what's actually used for xylazine withdrawal. These are just medications that a few medical directors have come together and said these might work. But again, we don't have any human studies. These are just recommendations, and they are not being implemented yet. We need to begin testing for the presence of xylazine. We need case studies. We need updated withdrawal protocols. The recidivism rates and AMA rates in the state of Pennsylvania are through the roof. They're over 50% because people aren't being treated properly for their withdrawal. We need to increase availability for medical rehab beds. What that means is if every single person from those photos came into my storefront tomorrow and was like, "I'm ready to go to rehab," where am I sending them with those wounds? Malvern's not taking them. RCA's not taking anybody with a wound like that. And we need to increase street side clinicians and wound debridement accessibility.
All right, so who is at risk for an overdose? The simple answer is anybody. It doesn't matter if you're just experimenting, if you just, use situationally, if you are chemically dependent on the substance, anybody is at risk of an overdose. Now, there are things that increase that risk, mixing your drugs, obviously how strong they are, how you use them. If you've overdosed previously, and we'll talk about that in a minute, tolerance changes is a big one. A lot of times we see people who get arrested or go to treatment. They might get released from jail. It might be 3 days. It might be a week later. They might leave treatment a little bit earlier or stay the full 28 days. It only takes 24 to 48 hours for your tolerance to decrease. So what happens a lot of times is people come out and they want to use drugs again, and they don't realize that their tolerance has cut in half. So they use the same amount that they typically would, and they're at a much higher higher risk of overdosing. Using alone. So 8 out of 10 overdoses actually happen when someone is alone in their home. People think, you know, especially we're in Kensington, that it's just everybody on the streets of Kensington is overdosing. That's not the case. What it is it's kids from the counties, right? They come down to Kensington, they get their drugs because of stigma. They're not telling anybody what they're using, and they go home and they use in secret, and nobody's with them and nobody knows what's going on, and they overdose alone. And then you have things like your physical health, dehydration, kidney function, weight loss, things like that. So this is the progression of an opioid overdose. And the reason that we have this slide up here is because if you look, your heart stopping is the very last thing that happens before you die. So when we talk about rescue breathing in a little bit, it's really important that you note that the heart stopping is the very last thing that happens. And we stress this because when we talk about rescue breathing, a lot of people get it confused with CPR, right? And we're not doing chest compressions. We're not doing CPR. Typically, when we respond to an overdose, someone still has a heartbeat. So we don't want to do anything that's going to interrupt the rhythm of their heartbeat. So high versus overdose. With xylazine in the mix now, it is a little bit more difficult to tell if somebody is just really high or if they're overdosing. And the reason that is because they're consuming an animal tranquilizer, right? It's doing exactly what it's supposed to do. These people are sedated. So the main things that you want to look for is their skin tone, right? You want to look to see if they're turning like a bluish color. If they have darker skin, they might be like purple or ashier. You always want to look around their lips and their fingertips. Obviously, if they're responding to you at all, they're okay, right? But you want to look for, sometimes we call it like the death gurgle, right? They might make a sound that sounds like they're snoring, like a, and it's actually like the air escaping their lungs, the last little bit of air. So that you want to look for. If their heartbeat's not like if irregular, or if their breathing is just labored, those are good signs. So our whole team carries pulse oximeters. I don't expect everybody in this room to carry a pulse ox with them around, but they're a really cool way to just tell if somebody is overdosing or not. We put this on their finger. Anything below 90, we start to respond, right? Anything below 70, oxygen is not getting to their brain. So how does naloxone or Narcan work? Now, as somebody who used drugs for 10 years, I had no idea of this, right? So I always thought that when somebody Narcaned you, right, the drugs were just gone. They were removed from your brain, you're sick, like that's it, you have to use again. But what actually happens is when somebody consumes an opioid, right, that opioid's only job is to find that receptor in your brain and sit on it, right, until your body metabolizes it and it's gone and you have to use again. When someone is given naloxone or Narcan, which is like those pretty little purple and white clusters, the Narcan comes in and it kicks that opioid off the receptor and it sits in its place. However, naloxone only lasts for 20 to 90 minutes, right? So in that 20 to 90 minutes, if the naloxone wears off and you still have that opioid in your brain, if your body didn't metabolize it yet, it will go back onto that receptor. Now, what we see happen a lot of times is somebody receives Narcan, they wake up, they don't feel well, and they want to go and use again. So we let people know, like, hey, that's only effective for 20 to 90 minutes, so you should be careful. You are more likely to overdose again. Now, usually when we tell people this, they don't care, right? But what can we do? We can let them know, like, hey, if you're going to let somebody know, take a Narcan with you, keep it visible, just because you are more likely to go out. So types of naloxone. So these are your standard one-time use 4 milligram spray. It goes right into the nose, super easy to use. Our team started carrying, with the increase of the presence of xylazine in the dope supply, we started carrying preloaded intramuscular Narcan. And the reason that is we can load up those syringes with 0.8 milligrams, 1.5 milligrams. Because the xylazine is not an opioid, right, but there's still a little bit of fentanyl in there, we want to give somebody enough Narcan to reverse the effects of the fentanyl without pushing them into a full-blown precipitated withdrawal. We call it a compassionate comeback, and we found that with microdosing the Narcan and rescue breathing, it's been super effective. So in talking about that compassionate comeback, right, I don't know if you guys have heard of Cloxido, but basically, what's it, double the amount of milligrams? Yeah, which is terrible, right? Because yes, it's super important to save somebody's life, but we don't recommend that because the drug supply is predominantly xylazine. There's no need to give anybody 8 milligrams of naloxone. It also leaves more opportunity for risk, right? If you give somebody the Opvi and it lasts for 12 hours, they don't know that, and people are going to try and break through that barrier, right? And what does that mean? They're going to increase their use, and they are much more likely to overdose again. So, first steps in reversing an overdose. You always just want to try and wake the person up, right? You want to get loud. You want to start with a verbal cue. Hey, my name's Mel. I'm going to Narcan you. 9 times out of 10, if you tell somebody you're going to Narcan them and they don't need to be Narcan, they will jump up and let you know, right? It's always good if you know their name to call out their name. People are likely to respond to that. If they answer you at all, they're okay. You don't need to intervene, right? If they don't, you want to move on to physical cues. Now, I've heard a lot of crazy things in my years of using drugs, putting ice in somebody's pants, throwing them in the shower, shaking them really hard, the sternum rub. Those are things we steer away from, right? They're not effective. The sternum rub can leave bruising, somebody could have a piercing, and just add more injury onto it, right? So we just want to do things that are going to warrant a response. So like a nail bed press, right? Where if you take your nail and kind of push it into where your nail meets your cuticle, it's a pressure point. It's uncomfortable. They pull their hand back. Cool, they're okay. You can do something like take the flat part of your finger right here, push it into your throat and kind of move it up and down. It's uncomfortable. If they respond, they're okay. If they don't respond to that, that's when you're going to begin the steps of reversing their overdose. So first thing you always do, right? Call 911. Super important. Call 911, and I'm going to put that on speaker and kind of use that as my timer, right? So I can track how long everything is taken. In Kensington, unfortunately, when we call 911, I don't say I have someone who's overdosed, again, because of stigma. I say I have an unresponsive person, right? Now, they don't know if I have somebody who's overdosing, somebody who had a heart attack. They don't know what the situation is, and they have to come. So I say I have an unresponsive person. I want to make sure that the person is laying flat on their back and kind of clear the area. You don't want to kneel down on a needle cap. You don't want to lay them down on a needle. You don't want to smack their head on the ground. And you're going to take the Narcan, right? It's one-time use. You stick it right up their nose. It does not matter what side of their nose you stick it in. You're going to get it up there as far as you can and push the red plunger. Now, the super important part, like we talked about, the rescue breathing, right? It is not CPR, but xylazine affects your respiratory system and people are not getting oxygen. So you're going to scoop their mouth immediately after giving them Narcan. People who use drugs sometimes will chew on stuff like a needle cap, a baggie, anything like that, and you don't want to lodge anything into their throat. So you're going to pinch their nose, tilt their chin, and you're going to give 2 strong breaths, right? Count to 5 and repeat that. You tilt their chin because you want to make sure that their chest is rising and not their belly and that the air is going into their lungs. Now, we have little CPR masks. You can use anything, though, right? You can use your hand as a barrier. You can put your T-shirt over their mouth. You can use a COVID mask just so you're not mouth-to-mouth with a stranger. But we've done it. Sometimes it's necessary. So you're going to pinch their nose, tilt their chin, 2 strong breaths. Count to 5 and repeat that. And it's exhausting, but you have to continue to do that. Now, you can administer a second dose of Narcan if 3 to 5 minutes has gone by of rescue breathing and you're still not seeing a response from them. But that's why it's super important that you used your phone as a timer, because we don't want to over Narcan anybody, right, if it's not necessary. And when you're in the heat of the moment and your adrenaline's going, it can seem like it's been 3 to 5 minutes when it has not been. Now, lucky for us, our team carries oxygen tanks. We started getting them about 2 years ago, and especially in the summer, they've just been super beneficial in reversing overdoses, rescue breathing. I know Sarah did it one time for almost 20 minutes, and it's exhausting to just be constantly breathing for somebody that long. We found with the intermuscular Narcan and just slapping oxygen on somebody that they've had a much quicker response. Now, also, a couple years ago, when it was primarily fentanyl, you would hear people say, like, oh, I Narcan somebody, and what if they jump up and hit me, or, they get scared that somebody's going to attack them. My grandmom carries Narcan, and she asks me these questions. But with the xylazine, when people come to, because there's so much xylazine in the supply, they're not up and moving, right? They're not up and running away. They're still so out of it, exhausted, don't really know what's going on. And that's why it's super important to let them know that they're in a safe place, right? As soon as somebody opens their eyes and makes eye contact with me, I let them know, hey, you're safe, right? My name's Mel. You just overdosed. I don't even hype them up, right? I don't just say, like, oh, we just Narcaned you. No, you just overdosed. Are you okay? Do you want to come inside? Do you want to call your mom? Can I get you a drink of water? But let them know they're safe, right? Another super important thing, too, is if you have somebody with you, we always make sure it's that person's job to kind of clear the area, right? Because you don't want a crowd forming. It's terrifying to come to and just have a group of people standing around you shouting things like, oh, my God, you were just dead, right? So to just be calm, kind of back up and lower your voice and reiterate to them that they are safe. What? Oh. So the recovery position is, so we use this for two reasons, right? One, if somebody starts to respond, and like I said, they're still very lethargic, you want to put them in a safe position in case they are to vomit or anything like that. They're not going to choke on it. Or like Sarah mentioned earlier, a lot of times we're just moving people around, right? They're sitting in uncomfortable positions. Their airways might be blocked. They might be cutting off circulation to a limb. And we use this position to just kind of get them, like, ideally so they're as safe as possible.
So after I've administered that Narcan dose, if he begins responding, I'm then going to move him into the rescue position. Every time I watch. Again, you're going to lift his hand above his head, like that. Take the opposite hand and rest it palm to cheek. Going to lift the knee slightly. Grab hold of the hip and the shoulder and always roll towards you. This way, when he begins waking up, he won't vomit or choke on his own vomit. His airways are open and his circulation is up. At this point, I back away a few feet and then I begin introducing myself because
All right, so yeah, after steps. So we used to say, right, when we would do this training, if the EMTs respond, we just kind of back up, our job's done, right? We let them know, hey, I gave them a dose of Narcan, I did rescue breathing, and kind of back up. Unfortunately now, even though we've been screaming about xylazine, people don't know, right, including first responders. So we let them know when they come, hey, you know, I gave her 2 doses of Narcan, I've had oxygen on her, could you please support their respiratory system? Just because their first instinct most of the time is to come out and hit them with another dose of Narcan, which what really needs to happen is they have to keep the oxygen running. And then it's always good to take a moment for yourself. You know, we get kind of numb to it and we don't realize in the heat of the moment that we just had somebody's life in our hands potentially, right? So it's super important to take that minute for yourself, regroup, you know, talk to somebody and not get caught up in the heat of the moment.
All right, so you guys just completed the training. That was a lot of information, and we went a little fast with xylazine and opioids and how to reverse an overdose. We do offer this training in person and virtually if you want to reach out. We also have a ton of different ways that you can get involved in the mission that we have. We have social media. I'm going to leave a ton of business cards up here, free Narcan. Additionally, we have fentanyl testing strips and xylazine testing strips, which through House Bill 1393 that just passed, it's now legal, and the counties are starting to distribute them for individuals to test the supply. I really appreciate you guys being open to this training and taking the time out to learn a little bit more about the drug supply and how you can be able to be a friend for people who are using substances. At the end of the day, harm reduction is for everybody in every community at every different level, whether it is for individuals who use recreationally, situationally, chaotically, socially, or they are dependent on substances. So I really appreciate your time. We have one more slide because I think Officer Flanagan did. Are you officer or what's your title? Chief? I demoted you. It's okay. He arrested me once, so. Did you want to go? I know I got this slide about the different kinds of social work support that you guys offer, so I wanted to give you an opportunity to talk about that if you want. And then one other slide, which we'll come back to. I need everybody to scan this and give us a 10 out of 10. But
So actually, Commissioner Myers addressed the Board of Health. We do have a counselor here, and we are taking a much different approach to drug addiction and other problems that even could steer you to alcohol abuse or drug addictions. So we've added a counselor, which is just unbelievable. We're going to be giving a Board of Commissioners report in the near future, and then a second report to our Board of Health once we get through the commissioners. But there are services very local, and one of the things that I hear about, sometimes it's hard for people to get help or that crisis in the middle of the night or whatever else. I do ask you to share that I think everybody is trying to do a better job. And, you know, nothing is perfect, but I think with people trying to do a better job, we want to try and get you help sooner than later to avoid a tragedy or a Narcan application. Stuff happens. We have to deal with it. We have to be responsive to it. That's why people like this or heroes like this are out in the street getting it done. So I just wanted to let you know there are some services right here in Radnor Township, and then our goal is to connect you and keep you connected to a web that supports you for a long time continuing on. And if you just want somebody to talk to or you're frustrated with a loved one, you can reach out to us. We have a team now that can just be there for you so that you can be strong for them. So I wish everybody the best.
There's the QR code. Thank you, guys. And yeah, we offer these trainings throughout the county and throughout the state. So if you work with people that you think might be interested in this, yeah, reach out. Thank you again. And that's it. Stay savage. What? You have a question? You wait till the end? Oh, are we taking comments? We'll be taking comments now. Oh, I didn't know that. Okay, the comment section has begun. Heather, take it away. Do you want the microphone? The people need to hear you.
Can I just stay in my seat?
I'll use this one.
Hi, I'm Heather King. I am a resident of Radnor Township. I have a husband who is celebrating 15 years in sobriety on Friday. Yay! I founded a non-for-profit 3 years ago, and I was lucky enough to go to a snooty cocktail party and find this lady. And through us meeting, we were able to support Savage Sisters, and on a few occasions, they've come out and given Narcan training. And I've done outreach in Kensington, and I was also fortunate enough to have them at my house in June of this past year. And I was left with a whole lot of Narcan, and like Sarah, I love my friends in recovery and out of recovery. They're in and out of our house, and in September, we had a guest staying overnight who was asked to leave a sober living facility, and around 8:30 at night, I heard something really horrible come from down the hallway, and I rushed into the bathroom and found someone unconscious in my shower, and my husband covered him up, my daughter called 911, and I ran for the Narcan. Now, I will tell you, I didn't do exactly all of the steps that Sarah taught me because I was panicking, sort of. It was like 50-50. But I saved a life. I reversed an overdose. I called 911. Radnor Township came pretty quick. I had fire department and the police and the ambulance came, and he's alive and went back to, treatment and is doing really well. But I would not have known how to do that if it wasn't for Sarah and Adam. So these training classes, like, you guys might not think it's happening in your backyard, but I can tell you right now, in 1 year I had 3 people, 1 we resuscitated and 2 that I buried. So it's real, it's here. So listen to what they have to say and take some Narcan as a party favor because it can save a life.
Thank you, Queen. We're still doing comments. Any other comments or questions? Thanks, Heather. I love you.
I just, again, want to thank everybody. I took a look around the room. It looked like we had about 30 people that came out through snow and ice and everything to come see this presentation. I want to thank Representative Browski for being here and taking this so seriously, and Commissioner Myers for helping us get this presentation set up through the Board of Commissioners, and Kiki, of course, for joining our board and sharing her story and her family's story with everybody. And yes, again, as was mentioned, there is stuff up here, and hopefully there will be none up here before everybody leaves. Yes. Oh, yes. And this has all been recorded and live streamed on YouTube. So when you get home, there will be a link where you can share it with anybody who wasn't able to brave the snow and ice tonight, and share it that way as well.